Swatzyna. He'll be talking to us about a variety of things dealing with looking at maps and diagnostics here in part one of his talk. Ron has published several articles, and I first became aware of his work years ago, and he had collaborated in an article looking at people who had brain injuries, and families were denying it and so forth. And I've actually used one of the quotes from his article in some of my presentations where the mother was denying this kid had a head injury, and they said, well, you see, he's never done anything like that. She said, well, he used to bang his head on the wall when he was a kid, but he stopped doing that. And of course, that can cause a brain injury. So at any rate, Ron, we're going to turn this over to you. Thank you so much for being with us today. And this is part one, folks. That's a typo he said in the first slide where it says part two. Ron, thanks for being with us.
Hey, I appreciate it. I enjoy the opportunity to come out. I love to teach, so this is something that's very near and dear to me. Now, although I titled it EEG interpretation, I do not do EEG interpretations, but I do have every one of them read by an electroencephalographer, and that's one of the points I want to make today, that I think it's very important of those of us that do qEEGs not to let, and you'll understand why at the end of this, not to let that valuable data just sit there and just look at the quantitative EEG when the EEG is so vital. Okay, now the purpose of a diagnosis is to identify a cause for patient's symptoms. That's the only purpose of a diagnosis, unless you're thinking about insurance companies for reimbursement. But actually, using symptoms to diagnose brain disorders is an archaic system that's been around forever, but we're kind of like in the dark ages still. I always use the example that if we were 150 years ago and I went into my doctor, or he came to the house and I said, Doc, I'm gaining too much weight, my toes are tingling, and I'm starting to lose vision, he'd diagnose me with vision loss, obesity, and toe rot. But that's not the diagnosis. The diagnosis is diabetes. So that's where we're trying to make the change in mental health right now, is to get some sort of what's causing the symptoms, not just identifying symptoms. Diagnosing a brain disorder without looking directly at the brain, therefore, is like diagnosing heart disease without an EKG. In 2012, Dr. Thomas Insel, director of the National Institute of Mental Health, he came up with this blaring statement, said the DSM is not a valid instrument. Now, this was a big statement that pulled the rug out from under mental health completely. And he said further that we need to find neurological causes for symptoms using scientific technology such as imaging, genetics, and biology. As it is, we now have EEG comes under imaging studies. And that's when they instituted the Research Domain Criteria Project. All right, the aim of personalized medicine is to provide the right treatment to the right person at the right time. There's no one-size-fits-all in brains, as opposed to the current trial and error process based on symptoms only. I refer to them as biomarkers or neurobiomarkers. They're the basis of this approach. Okay, now biomarkers, we've got biological, which are neurotransmitters and metabolites, psychometric ones, which are personality questionnaires, neuropsychological, cognitive functioning measures, and psychophysiological, which is EEG, ERP, and qEEG. Well, we're not going to discuss ERPs today because that's not my area of expertise, but I did want to mention that they do come under the psychophysiological measures. Measures in brain function in real time and quantitative EEG. What we're looking at in EEG, for instance, is a measure of brain function in real time, and the quantitative EEG provides comparison to a normative database. Of course, you guys know this. It incorporates nature and nurture effects in the ideal biomarker for predicting outcome and measuring responses. In ADHD, we found multiple neurobiomarker for the diagnosis of ADHD. Excuse me one second. I'm going to try to get this thing off my screen. It's bothering me. Okay. So there's no single test to diagnose. Similar symptoms are found in sleep disorders, produced by anxiety, depression, and learning disabilities. I can't get my screen to go down. there it is. The most prevalent neurobiomarkers in ADHD, in this is cases referred for EEG and qEEG. These are the findings that we have. And I'm sure many of you are familiar with all of these. Abnormal slow peak frequency alpha, which is a central nervous system underarousal or hypoarousal. A high theta beta ratio, which is what at least the FDA considers the only neurobiomarker for ADHD. Abnormally fast peak frequency alpha. This is those cases that we find that creates anxiety because they're just too fast. And then spindling excessive beta, or I call them beta spindles. The last written about in 1958 by Hobbs and Hobbs, when Fred Hobbs identified, and gave them F1, F2, and F3 beta spindles, until Martine and Arns came to me and wanted to do a paper on them. We published that paper, I think it was in 2014, on what we found with beta spindles. We'll get into that in a little bit. Anterior hypercoherent alpha, the focus of overconnectivity, especially in the frontal lobes. Focal slowing, encephalopathy, low voltage slow is actually what it would come out as, and epileptiform activity. Okay, abnormal slow peak frequency of alpha is very important. It tells us a lot of what to do with medication, but it's also associated with maturational lag or developmental delay. I work with a large population of children, and I found several children with this issue, and you always wonder, why isn't their brain aging at the same rate that which you would see their peers? I'm always trying to unlock that last little layer and identify what's causing the problem. Hyperactivity and behavioral issues are often common to this population, and central nervous system is underaroused. And this is how it looks at it on the EEG. It's very slow, but it's usually pretty high amplitude, as children's amplitudes are much higher than adults. But this is in a 14-year-old male, and obviously this is not a good thing for a 14-year-old male. You can see, I love these maps that are color-coded, so the theta is red and the alpha is yellow. You can see how skewed this is to the left, and we do have an underaroused brain with ADHD. I'm not going to spend too much time on this unless somebody wants me to slow down, because you guys know most of this stuff here, but I want to give it as a background. And I'm using ADHD because it's generally a diagnosis that's can bring in so many of the neurobiomarkers that we'll be looking for, or that we'll come up with when we do EEGs and Qs. High theta beta ratio, of course, you know, it's a slow wave over the frontal and central midline area with deficits of beta. Very distractible group. I call this my video gaming group, because these guys, the study in Japan found that those that were heavy gamers, once they took them off the heavy games, the majority of them had this pattern, and when they took them off the games, the brain did not go back to normal. So they get stuck in this high theta beta ratio group. And of course, the maps, these are the maps that I use from the Human Brain Institute, St. Petersburg, Russia. I like these maps. And there's a representation on this spectra. Then we have the fast peak frequency alpha group. These are the ones that have the superior declarative memory. Usually corresponds with anxiety and hypervigilance. This is a hyperaroused group. Sometimes we have found that there's 3 patterns, and this is one of the patterns that will develop PTSD if traumatized. I'll go more into that later. Hypervigilance can act as a source of increased distraction and appear as a variant of ADHD. And that's what this is the hypervigilant group. Of course, it's you can count those little the alpha in the back of the head and come up with the frequency on that. I like these maps that compare it to the normative database, which shows we have a lack of slow alpha and an excess of fast alpha. And if we have an excess of fast alpha and they don't have any slow alpha, that makes them very difficult. Makes it very difficult for them to relax. They can't just chill. That's why this is also the most often group that will abuse alcohol and drugs. So when I do alcohol and pot, I should say, when I do a feedback for a parent and then a child that's 8, 9, 10 years old has this pattern, 11 years old, then I kind of pre-warn them, we really need to do some work up front, because if they are stressed, alcohol and pot will slow them down and make them feel better, so they'll be self-medicating, and we'd rather have them have other ways to learn to calm themselves. Beta spindling, excessive beta or beta spindle, synchronous activity in the beta range. Now, the beta spindles are different than just the excessive beta. Seen in about 10% of ADHD and ADD cases. This is the second pattern that if they get traumatized will develop PTSD. It's also associated with pretty commonly with bipolar disorder, in that these are the folks that will get into a manic state and get obsessed with something and stay up for days at a time until they actually go through a process called adrenal fatigue, and they'll wipe out their adrenal glands' ability to support them, and they'll have the big crash, and that'll start their cycles. In the slower beta range, say the anywhere from 15 to 20 hertz, it can be in that range. It's usually associated with some sort of benzodiazepine or barbiturate abuse, and we do have to rule that out when we do find these beta spindles. When we did the study with Martijn Arns, it was Martijn Arns, Sebastian Olbricht, Jay Gunkelman, and myself. We found it associated with sleep issues, hyperactivity, and impulsivity. And the sleep issues were kind of curious for sure. Now here's beta spindles. Now you can see the spindling effect. This is the classic F2 spindles Fred Gibbs identified in 1958. They'll wax and wane. They'll be mostly anteriorly, but as you can see, we can see some spread to the posterior, to the parietal lobes back here in the back, and even some posterior temporal, like at T5, for instance. Now this is where, if you don't look at the EEG, you can't see the morphology. You can see excessive beta in a lot slower range, and you can just mistake it as, oh, well, that's good, or that's just a little anxiety. But these beta spindles are specific and have a specific pattern, a specific intervention that will help out. Anything more on beta spindles? Anybody have any questions up to this point? I know that Dr. Proler, who I use as my electroencephalographer, he'll identify them specifically and call the morphology out, and he'll often say when they're slower, could be associated with the medication effect from barbiturates or benzos. Anterior hypocoherent alpha. These are very creative individuals, distracted more so by their own thoughts, so they can look very ADHD. However, they can be very rigid and inflexible, and the way I like to explain anterior hypocoherent alpha is that the left-hand side of your brain and the right-hand side of your brain are doing the same thing at the same time. The default of the brain is survival, and survival is guided by the actual emotional centers of the brain. So the emotions are more located on the right, just make it simplistic, although we know it's a limbic system response. But these are the ones that actually are, they can become very obsessed, very anxious, and they're the ones that we find that often have an OCD overlay to it, and they'll get stuck in a loop. And it will always be, their responses will always be more emotional than they will be analytical or rational. And then here's a good picture of a 20-year-old female with ADHD, diagnosed with ADHD, but she actually has the anterior hypocoherent alpha. As you can see, excessive alpha in the frontal lobes when we look at the maps. And I don't have a picture of the actual coherence maps. I should have included those, my mistake. Now, if we want to look at just a quick little brief information about medication and why medication can be guided by a lot of this information. I'm putting together a guidebook for docs right now on patterns that we find in EEG and qEEG and the medications that would likely be indicated and which ones are contraindicated. Beta spindles, they came out in 2011 or 12 with Intuniv. Well, Intuniv, clonidine, the beta blocker approach, actually works very well to calm these beta spindles down. Next step up from that would be a Neurontin, which would take the excitatory neurochemistry out, give you a better GABA ratio, relaxatory to excitatory ratio. Followed by Lyrica, a little bit stronger. We don't see that used that often in psychiatry. and then anticonvulsants in general can affect this. Now, anterior hypercoherent alpha, these are the classic cases that are very anxious. Like I say, they can become they can become very obsessed, and these are the ones that respond very well to SSRIs. Now, if you had a fast alpha in this, you couldn't use an SSRI. It's too stimulating. You may have to use something different like a boost bar. We can get into medications in another time. Focal slowing. This is another pattern that we see. The problem with focal slowing is that you can't tell the brain, let's just take a look at this one part of the brain and ignore the rest of the brain. So medications don't work well. Neurofeedback works well, but we find it associated with traumas, tumors, cerebral vascular issues. I'll go into more of that later on. Inflammation and other known etiology. Okay, and this is right here is a focal slowing. You can see in the left temporal lobe. It goes actually all the way up from F7 to T3, all the way down to T5. And I don't recall which patient that was from. In the alpha range, if we have focal slowing, I've done a lot of work with head injuries. That's usually what we'll find after a period of time. After a head injury, alpha will go away initially, and then will come back at a slower frequency than the rest of the brain is. And this would be indicative of a gray matter injury. And they heal real well and wire around themselves real well. So most people come back just fine from gray matter injuries. Now there's another pattern called temporal mild, slow, and sharp activity. And this is related to cerebral vascular issues. Again, this is something that should be called by your electroencephalographer, because we can't call it. Making the distinguishing this from other abnormalities on the EEG is kind of difficult to do. It's kind of understated in the EEG, but a good electroencephalographer can pick up on this, and I'll tell you some cases where we've had that. And left anterior temporal lobe, but when we have the focal slowing in the left anterior temporal lobe, it correlates with a refractory depression. That's why the FDA has approved transcranial magnetic stimulation for the treatment of refractory depression, and it's because they happen to have the type of depression that is indicative of a left temporal lobe's focal slowing. And that's exactly where they say to put the magnets on. Okay, this is temporal mild, slow, and sharp activity. It's very easy to see. And it looks pretty common throughout this whole thing. It's not that impressive, but it's something that I think when the doctor calls it, you need to check either there's a problem with the blood flow in the brain or getting to the brain, which means it could be cardiovascular in the pump, or it could be cerebral vascular in the brain, or it could be something along that path between the heart and the brain. So somewhere in there, there's an issue that's causing this, and he will call it, and he'll talk about commonly seen to cerebral vascular insufficiencies. This is one of the quotes that I've always remember from him. I've had one patient that was 50, he's my age, almost 65 now, and we identified this in him, and this was like his third cue, and this popped up, and he happened to be a cardiac patient. And it ended up, we sent him back to his cardiologist, and sure enough, they had to put a pacemaker in, so his heart was not keeping up, and it was kind of odd to have a psychiatric practice refer a patient back that says that his heart may not be doing well enough. Kind of a different twist. Okay, focal slowing in the delta range, the 1 to 4 hertz, usually is indicative of a deeper white matter injury. Could be subcortical tumors or lesions. We recommend MRIs on some of these. 90% of the time you refer for an MRI, it's going to come back unremarkable, as they call it. But there are some that we definitely want to look at in regard to this type of activity. The next one is a low voltage slow encephalopathy. Well, this is something that doesn't show up very well on brain maps. It's just it's just the way it is. It just doesn't produce the same effect. You can see excessive delta, but what does that tell you? Unless you can, actually the person who needs to diagnose encephalopathy will have to be an electroencephalographer. We can't do that, not as MD or not as PhDs or therapists. So encephalopathy, I found this in about 10 to 15% of the children and adolescents that I see. And there's a lot of different reasons for low voltage EEGs. What this is it also prevents normal maturation. So these kids will be often very immature for their age compared to their peers. And it's truly a central nervous system underarousal. However, if the body's not supporting the brain for some reason, which is what's what caused the low voltage, then there's issues that can also be medications will not work in those cases. So I found the most common that I've run across in my 15 years of doing this is metabolic issues. We've actually identified there's a certain bursty pattern to the EEG that the doc can call, and it comes back that it's associated with Hashimoto's thyroiditis. So to be able to determine that 2 ADHD kids that came in to see me in the last 10 years actually had a thyroid issue that was unbeknownst to anybody was quite a change, because then you could not get any positive response and get a lot of side effects when you use stimulants, which would be the #1 treatment for ADHD, but it will not work, and it causes lots of issues. So we ended up actually taking them to a pediatric endocrinologist, and I identified that, yes, they've got Hashimoto's, and they put them on some sort of thyroid support medication, Synthroid or something. And guess what? The ADHD symptoms started going away, and these kids' brains started speeding up quite nicely. Toxic effects. I've actually had one case of a kid that ingested, and he was a son of an Egyptian man, born over here, but went back there and ingested something with DDT in it, an insecticide. At the age of 3 and at the age of 6, he started wetting the bed profusely, couldn't figure out why, and started having all sorts of ADHD issues and everything else. And the way Jay Gunkelman describes it, fluorinated hydrocarbons get into the fat tissues and slowly leach out over time, and to the point that they get to where they start affecting the actual pituitary gland as well as the thyroid, and they can produce these kinds of symptoms. So toxic encephalopathy is rare, but I have come across it. Electrolytic encephalopathy. The electrolytes get imbalanced. You can have the bottom drop out of the voltage on a brain. Hypoxic. Now, I had 2 boys, one 6 and one 8, came in. Both had been diagnosed with ADHD, and both little skinny boys. One had been put on medicine, had terrible response to it, and the other one was not put on medicine because the mother heard me speak and said, "I want to test my son before we put him on medicine." I said, "Okay." Both of them came back with low voltage, slow encephalopathy, possibly metabolic or toxic. I've got a checklist of things I go down through, questions for parents when I come across this, and ends up they both had sleep issues. In fact, one of the little boys snored. So I sent these 2 little skinny boys off to a sleep lab to get a rule out sleep apnea, and they walk in, and with all these thick-necked men like me, and people look at them weird, but they both came back with moderate sleep apnea. They were only satting at about 92% and less all night long. So the actual lack of oxygen to the brain while they were sleeping was preventing the brain from maturing. And when you've got that extreme loss of sleep or lack of sleep, your body does shut the power down to the brain, because your brain is the biggest energy hog. And so then I referred these 2 guys onto a ENT doc, and he took a look down their throats and said, well, if it's affecting their brain development, they look bad enough. And so they did tonsils and adenoids out on both of them. And 3 months later, I did follow-up EEGs, and found that they had both sped up to normal rate, and that their EEG now is normal power, and the ADHD symptoms were going away, and they gained like 2 or 3 years in behavior because now they were not behind their peers as they once were. That's again why we want to get back to the basics of this, is we want to identify what's causing the symptoms and try to treat it. We stand in a great position as neurofeedback and neurofeedback people that do EEGs and qEEGs. So that would be considered hypoxic encephalopathy. Then we can get autoimmune issues. I don't find too many of those. Encephalitis or meningitis can cause the brain to have some of these issues. Infections can cause it. Always look for, there's a possibility of low-level infections. And then trauma can cause it. You can get chronic traumatic encephalopathy. That's what's going on with all the football players. Okay, and this is what it looks like. So it's very unremarkable on the EEG, especially if you can't see what the microvoltage is coming out of this, and it's something that can be used in the future in order to develop some sort of concept. But again, the electroencephalographer is the only one that can call a low voltage slow EEG, or call it as encephalopathy as a diagnosis. Now, this is my area that really got me involved in doing EEGs and qEEGs. I used to do, I did the first 350 or so with Dr. Jonathan Walker, and pretty often he would come up and say, we've got spike activity, spike and wave activity located, and give me the location. So the temporal mild slow and sharp activity is an abnormal wave, but it's not a spike. Transient discharges, it could be considered in that. When we look at them, when they're paroxysmal in nature, they can be paroxysmal and still not be a spike, because it could be a deeper brain spike that's just now working its way to the surface and doesn't meet the type criteria of the speed that a spike would actually hit. I've done 2,600 EEGs now, and as many of these as I've done, some of these cases that I see Dr. Proler call, I don't see it initially. They're not big and paroxysmal, but they're still very, very important. And when he calls them, they're seriously, they're something we should pay attention to. A study by, who was that guy? I just had him down this morning. Hara. H-A-R-A, years ago, found that this activity in 25% of the children that you find spike and wave activity in will develop epilepsy by the time they hit their early 20s. Now, I think that's pretty accurate. There's a process going on called epileptogenesis, and this process is where it slowly grows over time and affects multiple sites in the brain, goes from a single focus to multiple foci. And it's very important for us to identify this. Now, we can't identify or call or even put into our reports that we've identified spike and wave activity or epileptiform activity in a record, because we're not board certified to read EEGs. And I see people, I've seen reports from other people that are doing reports for people, and they identify it, and you can't do that. We're stepping outside of our license. That's why it needs to be run past the electroencephalographer. Although our automatic spike detectors can pick up on it, it's still the gold standard in the industry is the eyeballer looking at each one of these EEGs. Causes can be include head injury, tumors, lesions, electrolyte imbalance, also, and infection. We see commonly there are, even though the locations of the spikes, the focus of the spikes or the sharps, does make a difference as to how it's presented. The cases that most often get referred to me, when I ask the clinicians, what do you think I'm going to find? They always say, you're going to find spikes. Well, there is something with aggression, neuroatypical behavior. Reading and learning issues can really be interrupted by a discharge like this in the left posterior temporal lobe for sure. But we find some things that is off-the-wall behavior, hyperreactivity to small provocation, boys more fits of rage and anger, girls more collapsing of mood and anxiety. And also we find this in these abnormal EEGs like this in people with panic attacks. I got a case in the other day and nobody could figure it out, and sure enough we'd identified this. We also find it in those that have gone psychotic or been psychotic, seeing or hearing things, or delusional, and antipsychotics medications make them worse. Usually it's found, if it's audio or visual, it's going to be in the posterior part of the brain. If it's delusional, it's usually hitting the insular cortex, medial temporal, and there's a way to look at that, but that's, again, back to the calling of the electroencephalographer. Okay, TMSSA, I'm back to this one again. This is also considered a transient discharge. This is a 55-year-old female over a 3-month period of time. She lost the ability to find words. She started dropping things. She was right-handed, lost the ability to sing, increased anxiety. The MRI came back unremarkable. They recommended neuropsychiatric testing, and they wanted to rule out conversion disorder. Well, I've known this female for quite a while, and I wanted to see an MRA. Jay Gunkelman sent me a paper by Niedermeyer, study done in 1989, that found that this activity was closely associated with cerebral vascular issues, mostly in women, mostly over 50. So it's like we got to keep searching. So a carotid Doppler was recommended and an MRA was recommended by Jay. And we finally got the MRA once it was denied by 3 other neurologists. One finally decided to do it. And the MRA was, this is as slight as this EEG is, this is it in T3, a little bit in T5, and you just don't see much there. It's not that impressive. However, what this turned out to be, I got a call from the doctor. You can see on the maps how it really stands out here on the left temporal lobe now, when we did the maps on it. So what this turned out to be, the doc called me August 31st, 2010, said, Ron, I think we need to get your wife into St. Luke's real quick. I said, why is that? He said, it looks like we got a 7-millimeter aneurysm in the paraclinoid area right behind her left eye. And that's exactly where the area I pointed to when I said there's a problem in this area here. And yeah, that was my wife. She had actually a 9-millimeter fusiform aneurysm. It had 3 lobes on. They couldn't operate. They had to go into a femoral artery, go all the way up, put a stent in, 3 coils, coiled each one of the lobes, and then another stent in to hold it in place. And this is what they call a widow or widower maker, because this one is like 3 minutes and you are dead, because that artery is about the size of your little finger. And when it bursts, it's just a rapid, excruciating, terrible headache, and you just bleed out that quickly. So I'm really cognizant when Dr. Proler comes back and says cerebral vascular issues, I'll start looking, because I don't want to miss something, have somebody die on us. Paroxysmal transient sharp and slow activity. This is sharp and slow. This is not spike and wave. It's paroxysmal, as you can see. Paroxysmal meaning it starts from a normal background, explodes, and then goes back to a normal background. And paroxysms and transients on qEEGs and EEGs are actually averaged out, or most often artifacted out of quantitative EEGs. So you'll miss these important findings. Now this was a heck of a finding. Shows a paroxysmal frontal dominant generalized slow dysrhythmia. This is Meyer's words. He wrote this to me, as well as sporadic spike discharge in the left posterior frontal region, suggesting the presence of lesion in this area. And this is the one, it's not that impressive on the actual maps because it's paroxysmal and it's intermittent and it doesn't happen all the time. So over time it's averaged out, or I imagine this part would just be cut out on most qEEGers before they make their brain maps. So this one right here turned out to be a 35-year-old male that had been diagnosed early in life with autistic spectrum disorder, more on the Asperger's. high functioning, parents very wealthy, sent him to the best special schools. Actually, he was one of the few I've ever seen go all the way through a 4-year college and graduate. But since he graduated at the age of 21, he had not been able to maintain a job. He'd been in the Meningers multiple times. If you guys know about Meningers, they're a pretty top-rated place. And then he was a patient of ours, and finally our doc asked me, he said, Ron, we're missing something. See what you can see on his EEG. So this came up, and it happened one time in 10 minutes. And this was, I think this was eyes open. And when that exploded, it's like, oh my gosh, what is that? And so my reporter said we should have it looked at. So we sent him down for an MRI. And it was interesting, when we did the MRI, this one came back as total agenesis of the corpus callosum. Basically, he had no corpus callosum. He was missing 200 million connections between his left and right hemisphere, a true split hemisphere individual. His mother said, oh my gosh, what can we do? I said, nothing you can do. You can't grow back those connections. Just change your expectations. So again, all the neurofeedback in the world trying to fix this guy's left and right hemisphere like together wouldn't work. We could probably get some gains with neuro, and we did get a little bit, but it was just a birth defect. And I'm glad we found it out, because it did help change the course of how he was perceived by his parents from that point on. This is the MRI impressions. Okay, spike and wave activity. This is a 14-year-old male with ADHD, and this is something we see pretty often, is occipital spikes. These have been considered questionable patterns. If you send it to a neurologist, they will not call it because it is a disputed pattern. But electroencephalographers, they're supposed to call these because they let us rule out whether it's something that has significance or not based upon what we have found in the patient themselves. This is a segment of spike and wave activity of 14-year-old male with ADHD. So it's, again, the ADHD, I don't think exists. Oh my gosh, this is another questionable epileptic character. Yes, it's on a 12-year-old female. Big spikes in this one. These are easy to identify. I love the S-Loretta maps. I think they're wonderful for trying to do some source localization, find out where it's coming from, and try to line it up with that part of the brain that's actually giving you issues or expressing itself as some sort of psychiatric or psychological issues, behavioral issues. And one thing I would like to do to kind of press this point is I'm going to switch off and see if I can get into first of all, before I go on with this little video, it's about 6 minutes long. Are there any questions? I hope somebody's still there. Somebody chime in.
Well, people are still here. Yep. Oftentimes, I think folks are used to waiting till the end, but yep, we're hearing you loud and clear.
Okay, great. Okay, I'm going to go on with this little short video. This was a TED Talk that was done, and it's on my website. You guys are more than welcome to download it to your websites if you would like, because I got it from actually one of my colleagues, Greg Chabonneau, up in Washington. Let's see if it'll work today. It was kind of down yesterday, but it should work. Got it under video clips. Down at the bottom. Right here.
When I was 10 years old, a cousin of mine took me on a tour of his medical school. And as a special treat, he took me to the pathology lab and took a real human brain out of the jar and placed it in my hand. And there it was, the seat of human consciousness, the powerhouse of the human body sitting in my hands. And that day I knew that when I grew up, I was going to become a brainy doctor, scientist, something or the other. Years later, when I finally grew up, my dream came true. And it was while I was doing my PhD on the neurological causes of dyslexia in children that I encountered a startling fact that I'd like to share with you today. It is estimated that 1 in 6 children, that's 1 in 6 children, suffer from some developmental disorder. This is a disorder that retards mental development in the child and causes permanent mental impairments, which means that each and every one of you here today knows at least one child who is suffering from a developmental disorder. But here's what really perplexed me. Despite the fact that each and every one of these disorders originates in the brain, most of these disorders are diagnosed solely on the basis of observable behavior. But diagnosing a brain disorder without actually looking at the brain is analogous to treating a patient with a heart problem based on their physical symptoms without even doing an ECG or a chest X-ray to look at the heart. It seemed so intuitive to me. To diagnose and treat a brain disorder accurately, it would be necessary to look at the brain directly. Looking at behavior alone can miss a vital piece of the puzzle and provide an incomplete or even a misleading picture of the child's problems. Yet, despite all the advances in medical technology, the diagnosis of brain disorders in 1 in 6 children still remained so limited. And then I came across a team at Harvard University that had taken one such advanced medical technology and finally put it, instead of in brain research, towards diagnosing brain disorders in children. Their groundbreaking technology records the EEG, or the electrical activity of the brain, in real time, allowing us to watch the brain as it performs various functions and then detect even the slightest abnormality in any of these functions: vision, attention, language, audition. A program called Brain Electrical Activity Mapping then triangulates the source of that abnormality in the brain. And another program called Statistical Probability Mapping then performs mathematical calculations to determine whether any of these abnormalities are clinically significant, allowing us to provide a much more accurate neurological diagnosis of the child's symptoms. And so I became the head of neurophysiology for the clinical arm of this team, and was finally able to use this technology towards actually helping children with brain disorders. And I'm happy to say that I'm now in the process of setting up this technology here in India. I'd like to tell you about one such child, whose story was also covered by ABC News. 7-year-old Justin Senegal came to our clinic with his diagnosis of very severe autism. Like many autistic children, his mind was locked inside his body. There were moments when he would actually space out for seconds at a time. And the doctors told his parents he was never going to be able to communicate or interact socially, and he would probably never have too much language. When we used this groundbreaking EEG technology to actually look at Justin's brain, the results were startling. It turned out that Justin was almost certainly not autistic. He was suffering from brain seizures that were impossible to see with the naked eye, but that were actually causing symptoms that mimicked those of autism. After Justin was given anti-seizure medication, the change in him was amazing. Within a period of 60 days, his vocabulary went from 2 to 3 words to 300 words, and his communication and social interaction were improved so dramatically that he was enrolled into a regular school and even became a karate super champ. Research shows that 50% of children, almost 50% of children diagnosed with autism, are actually suffering from hidden brain seizures. These are the faces of the children that I have tested with stories just like Justin. All these children came to our clinic with a diagnosis of autism, attention deficit disorder, mental retardation, language problems. Instead our EEG scans revealed very specific problems hidden within their brains that couldn't possibly have been detected by their behavioral assessments. So these EEG scans enabled us to provide these children with a much more accurate neurological diagnosis and much more targeted treatment. For too long now, children with developmental disorders have suffered from misdiagnosis while their real problems have gone undetected and left to worsen. And for too long, these children and their parents have suffered undue frustration and desperation. But we are now in a new era of neuroscience, one in which we can finally look directly at brain function in real time, with no risk, no side effects, non-invasively, and find the true source of so many disabilities in children. So if I could inspire even a fraction of you in the audience today to share this pioneering diagnostic approach with even one parent whose child is suffering from a developmental disorder, then perhaps one more puzzle in one more brain will be solved. One more mind will be unlocked, and one more child who has been misdiagnosed or even undiagnosed by the system will finally realize his or her true potential while there's still time for his or her brain to recover. And all this by simply watching the child's brain waves.
Okay, I love that video, and like I say, I show it often. When I did my research coming into our practice and published it in medical journals, EEG and clinical EEG and neuroscience, and I can't think of the other one, the Journal of Electrophysiology, we found that 32% of the children that get referred to me for a Q that are diagnosed with ADHD have these spikes, and 36.7% of the autistic children have these spikes. So you've got a 30 to 40% chance that every child you see with ADHD has these spikes. And if you don't know where they are, you can't set your protocols up in order to address the spikes, because neurofeedback does a wonderful job at reducing and eliminating these spikes. Neutral positive perfusion is what Jay Gunkelman often talks about happening when you do the 12 to 15 work. So that's one of the things I wanted to put out to the group, is that how important it is not to miss this subtle activity that's going on in a good portion. Now, if you know that these kids are on stimulants, antidepressants, SSRIs that is, or anticonvulsants, they will make the spikes worse. So we get the difficult cases in our industry, so I think it's something very important to put out to you guys, that you come across, you're doing the EEGs, it's very easy to have them read, and then you can also identify the locations and everything else and start addressing them. Okay, now I'm going to open it up for questions.
Okay, we're going to have to unmute everybody. Just give us a second.